You're watching Supporting the International Medical Graduate, IMG GP Registrar, produced by GP Supervision Australia and presented by Dr. Sonia Chatter and Dr. Simon Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
Welcome all. A topic which we thought it was high time to readdress more directly, this incredibly important topic of supporting our learners who have come from a country other than Australia and New Zealand. But I would like to very briefly introduce myself, because many of you will know me, Simon Morgan, medical educator here in Newcastle on a Wabakal country and education manager with GPSA. But you haven't come to listen to me. You've come to hear Sonia Chatter, who joins us from Brisbane.
So thank you, Simon, for having me. So as I am Sonia, I have my practice in Jimboomba. That's the scenic rim in Queensland, midway between Brisbane and Gold Coast. So I'm the clinical director there, and it's a teaching practice with medical students and the registrars. I supervise both the registrars under training under the IMG GP, as well as we've had ECRM ones, and I also do the FSP candidates, and sometimes we get the odd practice eligible pathway as well. So there's like a wide range of IMGs we have under supervision from time to time, but at the moment mainly the registrars. So my interest in the IMG journey comes from probably my own journey, because I've lived that journey and I do understand fairly all the pathways and what an IMG goes through. And now being on the other side as a supervisor, I also understand both ways. What are the things which we can do together better for the IMG to have a better experience, and as well as the supervisor or the patients of Australia to have this as a very smooth journey with minimum hurdles. I come from India, and in India I was an ENT specialist, and I was also in the teaching roles over there. And I decided to move to Australia for basically my children who were already in high school at that time, and I wanted them to do their medical school from Australia. I looked at the pathways, and to come to Australia as an ENT surgeon, I found the journey was very long and it wouldn't get me here a fellowship and a residency so I could get my children in the medical schools here as domestic students. Otherwise, I would have paid fortunes of fee for them as an international student. So I looked at a GP pathway, and interestingly, GP as a specialty was something new to me. In India, GP is not even a specialty. So this is one thing that many IMGs coming from certain countries, and mainly in the subcontinent and Indian subcontinent and countries around, do not have GP as a specialty. They haven't grown up seeing GP as a specialty. So this is one learning, that this is the major specialty of Australia. So if we talk about doctors in Australia, the main workforce, say, I don't know the exact percentage, but I think could be 90% maybe. So country we are shifting to where the main percentage of doctors are GPs. So we need to understand this specialty.
And isn't it a fascinating place to start, that literally the first thing that maybe an IMG needs is a sense of what is this? What is this gig? What is general practice? We don't even have that kind of thing in my home country, and to be able to talk about what general practice is in Australia, absolutely.
Right. And also the patients whom they have seen back home, they have not recognized that what's the pathway to their problems, that they first see a GP, and GP is the person who looks after them from what we say cradle to grave, right? So when we come here, and when I understood the concept of general practice, I was so impressed with it that this is one specialty where you, as a competent doctor, not only have an established relationship with the patient, so it's a relationship, it's the continuity of care. You don't see a patient just once and give a script or whatever, and that's it. So you take responsibility, that big word, responsibility of a patient's health, preventive health. These words, they are big here. And this is, again, when the IMGs start working here, they always miss preventive health. So even like just a simple consult, a patient comes to them today for a sore throat. But we need to make sure, okay, the patient is 40, has a blood pressure being charted, have you updated the family history? So preventive health starts working here, right? So that ways, when I recognized it as a continuity of care, something where you, as a competent doctor, have so much to give to the patient and so much to learn and then continue this beautiful journey as a relationship with the patient. That impressed me. So I changed my career from ENT to general practice. A, for what I liked it by choice. B, with my previous experience, I got eligibility to sit in the exam within 1 year. So I only had to do 1 year of Australian practice because I took the practice eligibility pathway. That was my independent standard pathway. I was not in any training program. I was not under any FSP. There was no FSP when I came. And within 1 year, I sat my exams. I cleared my exams all in one go. On the first day, I gave both AKT KFP together. And to be honest, I did not take any study leave. It's on records. I gave the OSCE. I worked till the day before OSCE. I cleared the OSCE. And I had my fellowship in 1 year after coming here. But there was a dedication behind it. There was a big dedication behind it. There was a goal. I had to get my fellowship and my residency. So my kids go into the medical school as domestic students. And they were already in year 10 when they came here. So and I did achieve that goal. I got my residency, and both my kids did medicine as domestic students here from UQ and beyond. So going forward, I continued my passion for studying and took up the roles as RSCGP examiner. I also did tutoring for GP Academy. I continued helping IMGs coming here. I tutored them for PESCI. So PESCI is an exam which IMGs do to start work here. I did help many others, known people for doing their fellowship exams, etc. So in the whole process now, as I supervise the GP registrars, I've seen that there is something obviously which we work about this. We talk about supporting the IMGs because we need to consider their backgrounds, what they have learned in their medical schools, what they've learned in their countries, what was the outlook towards a doctor, and was even the concept of general practice over there, which now we need to inculcate in them. And probably that's where we need to start journey of supporting the IMGs.
Sonia, what a wonderful both introduction and scene setting for what we're going to talk about. Thank you, because you've touched on so many important elements that hopefully we'll cover. Here's some learning objectives. These were pretty easy to write in that we really just wanted to cover some of those common important issues that face some, not all, IMG registrars, and also clearly practically how you as supervisors and supervision teams might either prevent or address some of those issues. So hopefully that's what we'll cover. Actually, there was some questions around non-AGPT supervision, and I might ask you very briefly, Sonia, just to speak to that, but we are very much focusing tonight on the registrar who's in training.
The non-AGPT doctors are, as I just briefly said, either under the practice eligible pathway, the standard pathway, or the FSP pathway. So basically they would be under limited registration. And I think that's beyond the scope of our today's webinars.
Yeah, thanks. And so I think the question there is, if you have an IMG registrar, I'm hoping you, in training in the AGPT, I'm hoping you all understand that they will be able to bill in the same way as an Australian graduate.
That's correct. If they are under the program, the training program, they get an exemption through the Medicare to bill the VR, they access the VR items. Yeah.
So again, I can't even hope to give such an authentic introduction as Sonia's just done, but let me speak a little bit to this. And Sonia, really interested in your thoughts along the way. But I'll go through this fairly swiftly. I made reference to the fact that in 2021, we ran a webinar based on the new, at that point, guide to supporting the international medical graduate that GPSA had just produced. I'll reference that at the end of this because we've just updated that, and that really is the repository of a lot of the content, and certainly a wonderful summary for you to review at the end of this. And right at the beginning of that are these principles of supervision of international medical graduate registrars. And really, I hope they resonate with you. Really, they are pretty universal and things that I'd like to think we use with all registrars, but probably a particular need for our international medical graduates. The first one, clearly this notion of stereotyping. You know, I've got a registrar from Pakistan, and it is, you know, my experience of registrars from that part of the world is this. Maybe there's some truth in that, but to stereotype, I think, is dangerous and does a real disservice. That's probably a pretty obvious thing to say, but there's a lot of implicit bias in the way that we live our lives, and so I think it is important to identify that. Again, Sonia, if you've got any comments, chip in along the way, please.
Yeah, I think you're completely right that even though they come from, so obviously they're big countries, big population, we can't stereotype. So it's again the same thing. Somebody could come from Pakistan and would be maybe not very good, and somebody could come from Pakistan and maybe the most excellent, or somebody from India again.
Yeah.
So we just cannot stereotype because it's all individual as well, how much hard work they have put in back in their country, what was their competence there, and now how much hard work they're ready to put in here. And everyone has a different elasticity to change, to adapt, and to adjust.
Yeah. Again, there's no order here, and this is not an exhaustive list. We talk a lot about deficit discourse, and you hear that often in conversations around Aboriginal and Torres Strait Island Australia, and how important it is to avoid that type of language. And I think absolutely for this cohort as well, yes, there may be particular challenges, but I think it's really important to see those as differences and also celebrate the unique benefits that international medical graduates can give us, as you can see there, in terms of second languages, working in disadvantaged health systems, and resilience to setbacks, which is interesting. So again, that's just a sort of way I think that's really important to frame a conversation and an approach. Expect the need for broad support. Now, that might be a blanket statement, but I think you, and actually Sonia's going to talk about a case in a second, that was a UQ graduate, so overseas born, but certainly a local graduate. So it's not like this is unique, but, you know, it might be that you are addressing support issues across a range of domains: educational, pastoral, personal, professional. So that expectation, I think, having a sense that, you know, it might be requiring a lot of support, I think is important and a good one to carry. Again, I don't think this is at all unique to the international medical graduate, but to have a really rich, open, supportive learning environment and a culture of feedback, and that's very much a two-way culture. We'll talk a little bit about cultural nuances of feedback later on, Sonia, but do you have any particular take on that in terms of how a registrar's background may influence the delivery of feedback?
Yeah, it's just to, I think again, the same thing, we can check that what was their experience in their country looking after patients, what was their system, so we can always educate accordingly that what is the difference here now.
Yep.
So again, owning the responsibility, looking after those things like confidentiality. Again, they do read it, I'm sure, when they come here. Before that, they do read it, but again, emphasizing again practically.
So comprehensive orientation we'll also talk about, but that all is likely to include more than just this is the tea room and here's the emergency trolley. I'm saying a glib statement. I know your orientations are more comprehensive than that, but it might be more a an element of a cultural orientation. It certainly may be an introduction to the town and the region. It may include the registrar's family if they're coming from a major centre and relocating to a rural area, which is the experience of international medical graduates.
There was someone who came here many, many years ago, so maybe a few decades ago. And so one of the neighbors said that come to our house, XYZ Saturday evening, and just get a plate. So the person, they took a nice plate and their cutlery and went there. They said maybe they don't have enough plates.
Bring a plate. Isn't that wonderful? You have reminded me in the preparation for this session, Sonia, we have also updated our IMG webpage on the GPSA website, and there is a reference to 2 slang lists. One, bring a plate.
I read them. I studied them. I downloaded from Google, and before coming from India, I went through the colloquial slangs.
Yeah, and they're very, very useful. Not only colloquial slang, but also body parts, where people may talk about their,
The first day, I got that.
Yeah, and people, the patient may have no idea what's being talked about. Again, this is really important for all registrars, but not being cavalier and involving others soon and quickly in terms of supporting the registrar if you are identifying that somebody's struggling. So there's some broad principles. And then I thought it was just useful to talk a little bit, and again, you could extrapolate this to all registrars, but early identification of the registrar, or in this case, the international medical graduate risk. And for those of you who have heard me talk before, I really like this parallel between clinical and educational practice. So as GPs, as clinicians, we always consider this range of things in our patients. We think about risk factors and a cause of the presentation. We think about prevention and screening and early identification. We might do some investigations to make some kind of diagnosis. We institute a management plan, and we follow up in safety net. And that is exactly what we do with learners. We do all those things. They have a background. We often implement some sort of preventative or screening activities. And if there's an issue, we try to diagnose the learner and manage them. And so I'm curious, again, this is broad and you could apply this to any registrar who might start to struggle, but we know international medical graduates are more likely to struggle. What are some screening tools we can use, and what primary prevention strategies can we implement? What do we do to try to screen, a registrar or prevent a registrar, and in this case our IMGs, from getting into trouble, from starting to struggle in a whole range of domains? Normalising help seeking, self-assessment of competence, an early observation of a consultation, a good comprehensive orientation, model collegiate support, review of notes. Thank you. So there's lots of things. The epidemiology of clinical presentations in Australia is often very different to that the international medical graduate has trained in and learned about. So just with any registrar, but maybe even more importantly, a clinical checklist, I guess a sense of what they have been exposed to and seen before and feel confident managing is useful. Some early assessments of their practice, direct observation, random case analysis, looking at those important domains. Again, all of which may be areas of need in some registrars based on their training. Those incredibly sort of basic consultation skills around patient-centered practice and gathering a history and clinically reasoning and formulating a patient-centered and shared decision-based management plan may be very, very foreign to our graduates from other learning settings, as may documentation. So they're all really important areas to think about. And of course, just as somebody said, I think just asking what their background, how they learned as a medical student or a junior doctor, how hierarchical was it, how they responded to feedback, All those things can really are important to identify so that registrars will respond well in your practice. We have developed a thing called an IMG assessment tool. I'm not sure whether this has much carriage, but this is another opportunity to flag it. If you Google that or have a look on our website, you'll find it. And it's really just a structured approach to a conversation with an international medical graduate, probably best done at orientation or early in the placement, to get a sense of whether there's some areas that they may particularly struggle across a range of domains. And just finishing off this sort of screening and preventative stuff, obviously our registrars coming through the AGPT are often offered, not always uptaken, but offered a range of sort of pre-commencement learning modules around a range of areas. So, identifying whether they were done, I'm thinking certainly with the RACGP of GP learning, GPT-1 modules like these ones. We talked about a good orientation across a range of domains, not just the clinical and administrative aspects, but some of those areas like professionalism and including the family. Supervision plans, again, this is another primary preventative strategy, something that we can implement to a registrar to really hopefully make it less likely that they're going to struggle. And this is around help seeking, as Shrishti mentioned, ad hoc supervision, formal teaching, and how feedback is delivered in the practice. And lastly, this call for help list, which I think is pretty well known about now, the work of Jared Ingham from a few years ago. This is a really, really useful tool, again, for all registrars, but particularly, I think, for international medical graduates. So I think that's a sort of section on what are the broad principles and approaches, and then what this is the undifferentiated, unstruggling, just the general registrar who's come in. What sorts of things can we do to determine whether they're more at risk of getting in trouble, or when I say getting in trouble, struggling in some way, and what can we sort of implement? And this all comes, as I alluded to, from the IMG guide, which has just been recently revised. There on the left, and on the right are the kind of the areas which in the old webinar, now 4 years ago, as you can see, we basically stepped through cultural, communication, clinical, reasoning, consultation skills, professionalism, teaching and learning, which I just think is fascinating to get a sense of how your learner may have learned and how that really may challenge the way they learn with you, and obviously some of the person issues. So I would strongly recommend, if you're interested in watching that webinar, which is on our website from a few years ago. That's a sort of the important, I think, but basic preliminary background to kind of set it all up. But really fascinated to hear of your experiences supervising international medical graduates, and particularly this notion of how patient-centred care doesn't quite equal patient-controlled care or consultation.
So this is after the direct observations, I love doing direct observations, and I saw many people in the chat also, they thought that it plays a very important role in learning. So we get to know their consultation styles, confidence, how they're rapport building. And if they're doing well, it increases the confidence that, yeah, they did everything well. And we can actually teach them better by directly observing. So I do tend to do a lot of direct observations. So, of course, a main part of general practice being the patient-centered care, we teach them. So this particularly applies to IMGs in the sense that sometimes the patient-centered care is interpreted by them as giving the patient whatever they want. But of course, that's not true. So it is not equal to patient-controlled consult. So this was out of a direct observation of a local UQ graduate, an Asian background registrar. I had to obviously flag the registrar after multiple observations done and needs to have some more education from the educator. So if people would like to comment on what they think is the patient control consult, any particular examples they would definitely have come across of any patient control consult. So the one I directly observed, I'll just go through that one. It was around a 45 years old female patient, visibly obese. She came to have a result of some ultrasound scan another registrar had ordered. There's also one thing I feel that the registrars sometimes struggle with is when they start in a practice, they don't have a regular patient base. So they do see, sometimes they work part time. So they just see initially the random patients before they build in their own list. So any patient can come with something. So that continuity of care or a therapeutic relationship is not yet established. So that's where it's a big learning for them as well. So, and this is obviously applicable to a local graduate as well. But this session is particularly focused on IMGs, but it's, of course, as the comments are coming, it is applicable to the local graduates as well. So this lady told the registrar, can I have a script of Ozempic just for weight loss? And then she said, okay, can I just, there was big reminders popping up, CST was due, etc. Oh, I'll just give me the home collect, I'll just do it. And she just left with a pile of few things that, okay, and there was no therapeutic relationship, no actual consultation being happening in that consult. So what I thought that a patient control consult to such an IMG or a registrar, could be a local graduate, is not equal to the patient centered care because outcome is not achieved. Yeah, like somebody's saying scripts. So scripts can be anything. I'm just here for my scripts. So that's something you just give and do it. But so a relationship has to be established, the core of general practice, doctor-patient relationship and continuity of care. So this is again applicable to every registrar. And for why we say the outcome is not achieved is what I just said, that if we just following the orders of the patient, a therapeutic relationship is not developed. It leads to inappropriate patient care. For example, this patient told my registrar that give me the self-collect pap smear kit. So there's so many things which would be missed. She was overdue. She could have examined the cervix. She could have collected it properly. If there was any prolapse or anything else happening at age 45, she could have looked at it better, and the chances of a proper collection, that would have been better. There was no preventive care. There was no follow up because she just ordered for whatever and she just wanted to leave the room after that. So it is important to be in charge of the consult. Yeah. And assertiveness is not rudeness. So you have to be assertive with the patient that this is what they've come for and they need to discuss it, setting the boundaries, structure of the consult. This is also part of learning in general practice. It comes in good communication skill, organizing your consult, having a good structure of your consult. So I think this at the end makes you a good doctor. And again, not generalizing IMG versus local graduates, but yeah, sometimes the communication skills and structuring things can be better with our local graduates as versus IMGs, but as IMGs can be outstanding. I'm myself an IMG. So it's just the seminar, this webinar is about supporting and improving things. It's not about finding faults, as Simon said, we're just wanting to improve things and support them.
So I'm interested, Sonia, what's behind this more almost unquestioning, acceptance of the patient asking for things and just delivering them and kind of losing control of the consultation? What are these cultural aspects? Are they fearful? Are they being overly polite? What do you think's behind it?
I think that there is a few things which go behind it. I would say number one would be lack of knowledge. So if your own knowledge is lacking regarding something where you want to explain to patient what it is, you yourself do not have the full knowledge, then you would just listen to the patient.
Yeah.
But if you yourself know, then you will definitely I'm not saying argue, but you will educate the patient.
Yep.
You will engage the patient because you have more knowledge to share with the patient. I'm definite. Personally, it always turns around. If you give good knowledge to the patient agrees to you. Always agrees. It's just the way you put forward. They
Yeah.
should see that the doctor is giving me confidently good information.
Yep.
That's what they need to see that.
So
And
Srishti talked about transactional models of care and that I presume the training and or the ratio of the ratio of the patient doctor in some countries doesn't support relational care, and so can be driven by the circumstances of the health system, can be driven by the training, and I know you're about to talk about patient-centeredness, and very much a kind of what do you need, I can provide it, and move on.
yeah. So one, it can be gaps in knowledge. Two, it can be obviously confidence issues.
Yep.
Yeah. So that's what you asked. What could be the reasons why it goes the patient control consults? So the other could be low confidence. So obviously there is some lack of confidence, a fear that you're new to a practice, you're starting seeing a patient, the patient is new to you, you don't understand each other's ideas, expectations. There could be a fear of complaint that the patient might put a negative review if I'm not doing what the patient is asking for.
Yep.
So, number one fear is fear of upsetting the patient and the owner of the practice, not understanding cultural expectations.
Yeah.
So,
And it's interesting, how the often the patient population is, either more or less like this, such that some patients are demanding, or maybe patient cohorts can be more demanding or directive in the way they interact with the doctor, and so it's not all the IMG's fault, of course. Yes, so lots of reasons for that, of course.
I mean, I personally experienced this thing that when you start, you're new, the patients do try to push things around you, and it's all these things put together. You should have, of course, the supervisors' roles are very important here. They should be supporting the IMGs. IMGs should be encouraged to seek help.
Yeah.
Like there was supervisors should not get frustrated if the IMG is coming asking questions or something. The support. So again, as you've written, that if they feel lack of support, knowledge gaps, low confidence, anxiety, fear, and of course the cultural awareness issues that can lead to patient control consults. So it will just become a vicious cycle of not establishing a good relationship, and then in future every consult starts becoming that, and we are teaching bad behavior to the patient. Then this patient is going to give the same behavior to the next registrar.
My understanding, Sonia, is around patient-centered care, that it is often not, it's not really a concept that's addressed in some or many overseas medical schools.
Yes.
And it is probably a really important aspect of a supervisor's support, is to talk about how to bring the patient on board, how to engage theirs, as somebody said, their ideas, concerns, expectations, how to involve them in a genuine shared decision-making process, all of which is possibly even quite not only foreign, but counter to this view that, well, I'm the doctor and I've got this sort of hierarchy, and the patient's looking up to me as the font of knowledge, and I really just to ask them what might be going on might even seem to impinge on my credibility, and so I need to practice in this way, and I'll just tell them what to do. Is that your understanding?
No, Simon. So actually, the new graduates who come now, IMGs,
Yep.
and registrars, because they come through all the channels of so many exams, the AMC, PESCI, clinicals, and all these exams are full of teaching them the Australian system of patient care, patient-centered care. So this is the first thing every panel teaches them, and every exam preparation to IMG teaches. And I also learned this. The first thing is it's everything is patient-centered. So we have to involve the patient in decision-making, patient education, giving them options is something different from what is there in the countries like, of course, the subcontinent countries where the doctor just decides for the patient, right? But it's because that aspect becomes overdone because it's been taught to have a patient-centered care, patient-centered care, that it ends up becoming a patient-controlled care,
Yeah.
which we need to work on, that the doctor still needs to be the in charge of the consult, and the final decision, it's the doctor's script, doctor's writing it, but it is in patient's, like, educated, patient is educated and patient is agreeing to that decision. So it's patient is not directing the doctor to give me this medicine.
Yeah. Yeah, we haven't spoken about communication and language
Language
barriers
barrier. Yeah, that's quite important.
specifically. So what the
Come
IMG
across
is
that.
intending to say is not necessarily what the patient hears or receives, open and sharing feedback and coaching them on language. There was a question, Sonia, around support for communication and language issues. Do you have any good sources for supervisors who think, great registrar here, but heavily accented or some real
Yes.
issues with
I
language?
did have a Bangladeshi registrar. He had a very thick accent. He was very sweet, but definitely, like, there was some cultural or whatever. He used to smile a lot for everything. So he used to smile after everything. And so there was a patient who came to him asking for a script for a pill. He did not have much knowledge as well, and he had not read that part. So he was calling from his room to me again and again, and he was laughing every time he was calling. And the patient got a bit offended, and she did complain that he was laughing at me. But he had a very thick accent, and that laughing was something cultural. He used to smile every time he would cross across the corridors. He would smile. I mean, he was a very sweet person, but the patient didn't think that was appropriate. And he had a thick accent, so the RSCGP had organized, we had flagged it with his medical educator. So they had organized, she was a speech and language, somebody for communication. It was a non-doctor role, and he
Yep.
got sessions to improve his communication.
Yeah. So the RSAGP have communication skills specialists. I don't know if we've got any ACRM supervisors who have had experience. In fact, I was talking to one of the ACRM supervisors last week and saying, I don't know what they have, but it would be good if they do. The communication skills specialists are quite new, and they really, this is often in the context of a focused learning intervention if a registrar's been unsuccessful in an exam, or hopefully before that. And they can do some really quite intensive language support, as you say, Sonia. I don't know people's experience of Doctors Speak Up website. I keep hearing it's up and then it's not up and it's sort of not functional. That's been a bit of a go-to. There's a website called Star Pronunciation, which I'm aware of, but I've never used. We used to recommend people watch Home and Away, and they pick up slang and colloquialisms and accents and all sorts of things. I don't know that I'd recommend anyone watch Home and Away, but maybe there's a better soap these days to watch. ABC News, in the clipped English Australian ABC News readers, yes, that's probably the place to go. That's good that IMG registrars often have a strong clinical base, highly motivated, and in comparison to some Australian graduates who are not up to scratch, they're excellent registrars. And so, absolutely, this is very much so much of what we're talking about refers to all registrars. But I think some of these things can compound or be more exacerbated in our registrars who have come from a different cultural language training setting. It's such a rich area to learn about and to read about, how medical schools in some countries, the way history taking is very much just an interview rather than this dialogue that's often taught, or that is taught in Australian medical schools, and how uncertainty is something that's quite unacceptable, and really to sit with uncertainty is not something that's taught in some overseas medical schools. So as you said right at the outset, Sonia, some of these things need to be almost unlearned.
All these things, listening to local thing, news, also with the local culture. So, for example, how, at least I'm a semi-rural kind of thing. So how they keep chooks, what kind of animals they have, what kind of rural life they have, talk about their horses. Like my patients have alpacas and I don't know in what all. And so trying to learn what's their culture here, those things also help a little bit,
Yep.
engaging with patients and to know about them at least.
Yeah, yeah. So, in thinking about this, in reviewing the guide which we did for this webinar, in talking to Sonia about preparation, I mean, this is not in any sense an exhaustive or comprehensive list, but a few things. So, have a look at our IMG IMG self-assessment tool that registrars can work their way through and that a supervisor can use. Again, you could give this to anyone really, any registrar, and it's useful, but I think it's particularly focused for IMGs. So a tool is useful. Think about screening and early identification, really, really good to get a sense of who might be at greater risk and you might need to keep a closer eye on. Again, all these learning needs could be for Australian graduates, but I've put these ones here because they are often a reflection of the registrar's experience of learning in their home medical school, or just an absence of, say, reflective practice. What, is that a concept that they're familiar with? Ideas, concerns, expectations, patient agendas. I'll refer you to our study skills guide if you're not familiar. And again, Sonia, maybe you can correct me if I'm speaking, and I'm stereotyping probably to a degree, but I understand a lot of overseas medical schools and practice is around rote learning. So just if you read enough, you'll be okay. Whereas we know in general practice training, it's all applied, it's all contextual. And so it's not enough just to read it a lot. It needs to be put into some sort of context to be successful.
That difference does exist because I've seen my children's curriculum here and how they did the medicine here, and I did medicine in India. So I've seen that difference.
Yeah. And obviously the whole range of cultural nuances. And there's a wonderful book called The Culture Map by an American, I think, academic called Erin Meyer. That was the basis for a webinar we ran maybe 2 years ago now. And again, a webinar I really strongly recommend if you're working in this space. And in her book, and our presenters talked about her work, how not even, this is well beyond the scope of medicine, but how cultural nuances in communication and feedback according to the country of origin, and that's clearly, again, making a broad sweeping statement, but can influence. So they talk about direct and indirect communications. For some of the Northern European countries, it's much better to be very direct. For some other countries, it might be much better to be a little bit softer and less direct. A very interesting area to have a look at. So suggesting appropriate phrasing. So, that's where I think little mini role plays and kind of, this is how I like to explain tennis elbow, or this is how I would have, I think it's really good to draw a diagram or to use this analogy, and registrars may really find that useful. And also demonstrating best practice, role modeling, getting them to sit and watch you practice, as I say, role playing, and even using videos of your own practice to say, I'm doing this because of these reasons, and it might be something they haven't really considered. Disclosing your own vulnerabilities, I think, is so important. That's part of that a learning environment. It's very open and two-way, and will allow the registrar to feel more comfortable acknowledging their own learning gaps. And that whole sense of, and I'll put that there, got their back, because who knows what getting one's back means to somebody who's, grew up in Brazil. But, you've got their back. I am going to look after you. I'm going to support you, and, come along if you're struggling. So there's some useful tips, I think. Sonia, any comments on those? We've got just a few minutes before we finish up, and I'm just going to cover some resources.
No, I think it was a very important thing, and working together, it's just we all aim to just one outcome, that the IMG gets a smooth journey, gets assimilated in the system, and there's good patient care, the patients feel benefited. I think there was just that one thing we need to work on a little bit more, is that the communication skills, the accents, and how to improve that. That thing I still feel, yeah, it comes up everyday basis.
Yep.
That patients do come and say sometimes that I couldn't understand the accent of the doctor.
Yeah. The other thing that I haven't put in this presentation, and I think it's really, really important before we close to flag, is that in this country, like I'm sure every country in the world, there is racism, and our international medical graduates will be subjected to this. It's a very, very common experience, I think, for people from who were not born in this country, and indeed for our Aboriginal and Torres Strait Islander Australians. And I think identifying that that's occurring, seeing what sort of impact that have, obviously doing what you can to minimise that, being very open and supportive around that, making a practice culturally safe for all is critical. I guess in a sense that goes without saying, but I think it's also incredibly important to flag that. Got a few minutes left. Let me just flag some of our resources. So this is the new guide, freshly off the press. So have a look at that. And like all the resources that we've developed for supervisors, I think these are really useful for registrars to read. It's absolutely pitched at you as a supervisor, but registrars will, I think, really value this, as they will most of the things we write. We've got a communication skills toolkit, so have a look at that. The study skills guide I've referred to, which is all about effective study strategies, and of course lots of other guides that may be of relevance. We've talked about cultural nuances, and the other cultural aspect of a registrar's experience, I think, coming from a country other than Australia, is of our First Nations people, and for them to be able to be culturally safe with Aboriginal and Torres Strait Islander Australians is also incredibly important, so that we have a guide and some resources in that space. Teaching plans, which include consultation skills you may wish to use or refer your registrars to, and the old webinar, which really walks its way through this guide, might be something you can have a look at. And just for it, lastly, I was referred by a colleague working at Avant, one of the MDOs, of course, and I didn't look exhaustively, but I'm sure most of them have an equivalent suite of resources. But I was really taken by this little guide that's only just been published. This is actually available for all. You don't need to be a member. And it covers a bunch of, and has links to a bunch of things that I think IMGs may find, all registrars, but maybe particularly IMGs may find really useful, as you can see that sort of content. And this is on their website. I think some of this, if not a lot of this, is you need to be a member for, but I'm sure every MDO will have something similar. So there's lots of good resources, Medicare, prescribing, regulatory system, and some, communications, all these communications, difficult conversations, and there's doctors speak up. So lots of good resources. It's just a question of identifying them and referring your registrars to them.
The last one, how to support the practice managers in their role to improve the support. It's a wonderful question, and our practice manager does it well as well. I think on the same lines, maybe you also need to learn their background, their cultures, maybe their festivals, have a little bit of, let them feel comfortable, probably involve them in Aussie festivals, things like that, so kind of assimilation between the both.
We are now General Practice Supervision Australia, not Supervisors, and so when we think about the supervision team, practice managers are very much part of that. Thank you for coming along, but a bigger thank you to you, Sonia, for your contributions. There's probably a lot that you haven't said in the background. of your journey, your experience, but what you have shared has been, I think, incredibly helpful, and those reflections have been great. Thank you so much.
No, I just love it being here, and I think it was very good. I had a great journey.
Well, that's wonderful, and I love the passion that you have to make the journey for all our international medical graduate registrars similar to yours, as smooth as it can be. And, you know, often there's dislocation, often there's challenges here and there, but if we can make it as good as it can be, I think we're doing a pretty good job. Thank you so much.
Okay, bye. Good
All right,
night,
bye-bye.
everyone. Okay, bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.